So a very well-informed patient of mine asked me to compare my video, to take a look and compare my videos to Dr. David Diamond. Dr. David Diamond is a psychologist, a neurosciences professional at, I think, University of South Florida. And he's on a lot of YouTubes talking about statins. He wouldn't use them. I do. But he and I say a lot of the same things. Actually, once you start looking at the video, and I decided to grant the request from my patient and actually do a video and compare the two, you can see why things get so confusing. But at the end of the day, we have a very good reason for very different conclusions. And I'll cover that a little bit later. But first, an introduction. My name is Ford Brewer, F-O-R-D, Brewer, B-R-E-W-E-R. You started out my career as an ER doc, got very frustrated with what was going with all the unnecessary heart attacks, strokes, trauma, and decided, you know what, even if it makes a bureaucrat out of me, I'm going to go study prevention. I went to Hopkins, ended up running the program there, and was on a plant-based diet for about 30 years. I was a poster boy for prevention, lifestyle. Lifestyle is medicine, all of that. Low-fat, high-carb, plant-based type of diet. And was expected to do a victory lap when I got my first CIMT about 3 or 4 years ago at age, let me see, that was age 57, so 3 years ago. And I had a plaque in my carotid arteries. Actually, if you look at the aging nomograms on here, my arterial age was 73. I was not happy. I didn't get to do my victory lap, and I was very concerned about having that kind of problem. Actually, as I went on, I developed atrial fib. I have the atrial fib risk gene, and I've been an endurance athlete. Both of those things increase your risk for atrial fib. I've covered some of those in different videos. But I still will use statins. Dr. Diamond does not. Now, why? And first of all, again, where is this? I will put the Dr. Diamond's video with STEM. STEM is an excellent group too. It stands for Science, Technology, Education, and Math, I believe. And this is episode number 41. And again, sorry about the blurring, Dr. Diamond, and to the other viewers. I tend to have really bad quality on my videos. I've tried several ways of fixing it. Won't get into that digression. But I will, again, go through a lot of the basic material. I did, by the way, listen to more than that one video. There were some things that Dr. Diamond has covered in other videos, like I do understand, a quote, for example, he says he does understand that statins can impact cardiovascular inflammation. I don't believe he mentioned that on that STEM episode 41 talk. So again, some of these quotes are coming from some of the other videos from the same individual. But the first few minutes of this individual talks about, the first few minutes of STEM 41 with Dr. Diamond, he talks about the big fat lies and calls Ansel Keys a bully, I believe. And frankly, I think he was right. I think, everything I know about Ansel Keys would indicate he very well may have been. He says that that critical data was left out of the 7-country study. I agree 100%. He says that there was significant lost data in other studies that were that came out of Dr. Key's group, and that it misdirected us and science regarding diet for about 5 decades. I still agree 100%. And in fact, this is the image. Time magazine started out saying Ansel Keys is the guy. He's getting us off of fat. And then 50 years later, fat's where it's at. So he goes on to say, Dr. Diamond goes on to say, fatty acids, arachidonic acids, egg yolks, even bacon and butter are good for you. I just did a mini series on those same topics, the lost data, the fact that these fats are not bad for you, or at least that data did not support it. If I can remember, I'll put those in below this video. So again, 100% agreement so far. One of the David Diamond says he's quoting a lot of different studies and researchers as he presents. One of them I noticed there was somebody I'm a big fan of, David Ludwig. Dr. Ludwig is a physician, PhD, as well. PhD, I think, in nutrition and physician specialist in in endocrinology. He's at Harvard, and he wrote the book, Always Hungry. And basically, what we're saying is David Diamond, like myself, went from a low-fat, high-carb diet to a low-carb, high-fat diet. Diamond used to be a tennis buff, as he said, and he used to play some good tennis, get that exercise that he needed, but then he would cap it off with Gatorade and a muffin. So, yeah, I did similar stuff when I was younger because Gatorade was just, sugar in the water, which was not a problem, right? And the muffin was just carbohydrates, which was not a problem, right? Again, for many decades, that's what we believed. And I would agree that those probably did increase my risk somewhat, but I think the major risk that I have for insulin resistance, more than anything else, is my age. I'm 60-something years old. And obviously, I'm not obese. I keep a BMI in the low 20s. It could be a little bit lower. It could be 21. Right now, it's 21 and a half, maybe 22. So the next thing that we talk about, I think I'm getting these in order, statin risks and benefits. He quotes Paul Ridker from Brigham and Women's at Harvard on several things. One is that the medical standards should not focus on LDL. He also quotes him on saying, I think, any benefits from statins have nothing to do with cholesterol or LDL lowering. And yes, statins do have some anti-inflammatory effects. So yes, he's aware of that. I hope he's aware that Paul Ridker. Well, we'll talk about the other piece. We'll connect the other dot with Paul Ridker in a few minutes. Anyhow, I couldn't agree more. Everybody's focused on LDL. The medical community, most of them, the standards are written on LDL. And I would agree with Ridker and with Diamond. LDL is not a major risk factor. And guess what? We have that. We've known that if we just looked at the data for decades. This is from Framingham. And look at Framingham. If you're HDL, this is HDL on this side and this is LDL. So increasing risk with increasing LDL this way, increasing risk with decreasing HDL this way. Now look at this. If you go from 100 to 220 on your LDL, you get a very small increase in risk if your HDL is 85. A little bit more increase in risk if your HDL is 65, but look what happens if your HDL is 45 or even as low as 25. These low HDL areas are where the risk really comes into play. And it goes all the way up. Even if your LDL is as low as 100, but your HDL is as low as 25, you have significant risk. And again, that's coming from low HDL. It's not coming so much from high LDL. Now, I almost skipped over a good point. Again, maybe not in this video, but in some other videos, Dr. Diamond has mentioned, yes, there are people for whom high LDL is a problem. And he mentions, I think he does even go on and mention familial hypercholesterolemia. And he's right. 1 out of 500 people is heterozygous for familial hypercholesterolemia. These people do have, as he's mentioned, they'll have young heart attacks and strokes. And if you square that 1 over 500 squared, you'll get the frequency of homozygous familial hypercholesterolemia. And these people have heart attacks and stroke as teenagers, in their 20s. Those people have very high risk, and it is due to LDL. The vast majority of other folks really do not have that much risk from LDL. Again, they get it from other things like decreased HDL and insulin resistance. Now, he goes on to, this comment about low-dose statins, I believe was in an interview. It's like other toxins, poison is in the dose. That's the quote that somebody gave. I used to be a toxicologist, and frankly, that's very true. The reason medications make it to the prescribed list is they're toxins. They have poison components. And when you look at poisons, the dose is the issue. And I do actually use low-dose statins, as I've mentioned before. We'll talk about that a little bit later and why. Dr. Diamond has 2 reactions to that. Number 1, he said, look, you're focusing on cholesterol, LDL again. Why take the statin, even if it's low dose? Because lowering cholesterol is not going to do any good. And then when he deals with the inflammation issue, the issue is, well, if you're giving somebody a low-dose statin, yes, it may help, but it's not dealing with the inflammation at the source. Well, that's a place where, again, I have to disconnect because, yes, I would agree 100%. Lifestyle is what drives our health. But I have a lot of people who need help in addition to their lifestyle or while they're getting their lifestyle going. And again, this happens and gets worse and worse as we get older. So that's the first chink in the armor, I think, or the first disagreement. Maybe it's a chink in my armor. We'll see. So genetics and statins. This has to do with the KIF6 kinesins. I'm really not going to argue that much. It gets fairly technical. Bottom line is, I don't really use the genetic testing either. Most of my patients have had it because the KIF6 is included in the cardiogenetics panel at no extra cost. And unfortunately, it tends to confuse things. So again, a place where David Diamond and I would agree 100%. Criticism of Big Pharma. Yeah, there's been a good bit of criticism of Big Pharma. I didn't really hear that in any of the videos I listened to, although there were questions about it. There were statements of, there are 3 kinds of lies, damn lies, and statistics. That was attributed to Benjamin Disraeli. Now, this was the interviewer that was interviewing Dr. Diamond, but I think they were pointing out the point that he's made a big deal out of arguing with pharma and saying that they were using damn lies and statistics. As I listened to his response, I'm not so sure. He said, look, I'm in psych and neurosciences. I believe he's a psychologist. I've had grants from pharma. I would take grants from pharma again. Here's my issue. As I look at big pharma and cardiovascular disease, I don't think big pharma's done that good with cardiovascular disease. Well, I don't think I would argue that much about that, and I clearly wouldn't. That's not a significant difference, I think, in terms of where we land. Now here starts to get to be the issue. It has to do with the oft-quoted criticism of the Jupiter study. And you may recognize this face. It's Paul Ridker. He's the principal investigator of the Jupiter study. He's also the Harvard cardiologist that has been focused on inflammation for decades. And he's also the Harvard cardiologist that Diamond quotes in terms of saying our standards are too focused on LDL. So here's the issue here. At the end of the Jupiter study, Jupiter was where they gave rosuvastatin to see about rosuvastatin or Crestor, to see about decreasing the risk for heart attack. Now, the quote that I heard, I'm going to put it down. I think it was inaccurate. I wouldn't thump him for the inaccuracies on the statistics. He said 0.7 incidence of heart attack or endpoint versus 0.4 in the Crestor group, and that it was reported as almost a 50% decrease. Well, that was relative risk, and he has said multiple times, I'm offended that they would call that an almost 50% decrease in risk. My kudos to David Diamond for understanding the difference between relative risk and absolute risk. The actual number, by the way, was 1.36 versus 0.77, but still accurate enough. It's good enough for what we're talking about here. I'll actually even quote an ally of the same point. This is healthnewsreview.org reporting the findings, absolute versus relative risk. And you would think their quote, their example is coming right out of the Jupiter study. So they said here, there's a new wonder drug that reduces heart attack risk by 50%. When the reality was the new wonder drug reduced heart attack risk from 2 per 100 to 1 per 100. So, same facts, very different interpretation. So, I've even marked out new wonder drug and put in rosuvastatin for the Jupiter trial. But here I'm also pointing out, here's where the problem is. The difference between relative risk and absolute risk is very significant for a low probability disease. And guess what? Let's go back to Jupiter. Jupiter looked at 50-year-old men who had no apparent risk and 60-year-old women who had no apparent risk. The incidence of cardiovascular inflammation and heart attack and death for that population is very small. In fact, we can go back and look. It was reported as 1.36. So I would agree. If the incidence of if my probability of having a heart attack over the next 25 years is only 1.36%, I'm not going to take a statin either. My absolute risk of having a heart attack is very, very low. Therefore, cutting that risk significantly is not going to help that much. In fact, I'm going to go back and apply this to Rory Collins and his Lancet group. These guys are unabashed. Well, I think unabashed. It's the statin study group. They're pro-statin guys. But here, they start giving a good set of numbers, and that helps us understand the possibilities and the issues here. They said, okay, myopathy cases, 5 per 10,000. New onset diabetes, 50 to 100 per 10,000. Hemorrhagic stroke, that's pretty much been debunked. So yes, you're talking about significant numbers of side effects. So yes, statins are dangerous. Why do people keep saying, well, go ahead and take them? And especially if the risk factor is 1.3% for having a heart attack or stroke. Well, no. This group, if it's moderate risk, they're saying 500. And if it's a high-risk group, it's 1,000. In other words, 5 to 10% risk of disease. And that's just over a short time period, 5 years. Once you multiply that out times 25 years, again, much higher risk of having disease here. In fact, what I did was I went back and I applied the low incidence rate seen in Jupiter in the healthy 50-year-old population to this group. If you looked at Jupiter incidence, the non-study group at 1.36 would have 136 heart attacks. The treatment group would have, at 0.77 rate, would have 77. So in fact, if you looked at that low 50-year-old, otherwise healthy group, probably don't need statins because they saved 59 people, but they created more than 59 problems. So, bottom line, no, if I've got a 50-year-old that doesn't have cardiovascular inflammation, doesn't have plaque, doesn't have positive inflammatory tests, doesn't have a positive coronary artery calcium score, I don't recommend statins. I guess we could all say we actually agree in that point. However, if I've got a 65-year-old with a calcium score several hundred, with positive inflammation and cardiovascular inflammation, and elevated hsCRP, elevated microalbumin creatinine ratio, plaque 2, MPO, he's struggling to get, I'll tell him to lose weight if he needs, and many of us need to lose weight. I'll tell him that. I'll tell him to work on his lifestyle. But I'm also going to give him a statin because that individual has a much higher than a 1.3% risk of disease. This has been a very long video. I really appreciate your attention. And Dr. Diamond, again, major kudos to you for understanding a lot of these basics and even subtleties, including the issue of relative risk. Please don't take these as criticism. I think you've gotten much further than the vast majority of the medical community who does this for a living. Thank you again for your attention.